Next talk, Dr. Manoj Jondhale.
Good afternoon, everyone. This is Dr. Manoj Jondhale. I'm going to present today the topic Transoral laser resection in early glottic carcinoma. Starting the stats about the laryngeal carcinoma, it is the second most common head and neck cancer. It's a balance between the primarily the oncological control, the organ preservation, where to possibly restore the form and function while minimizing the treatment morbidity. Considering the global stats, the incidence of the laryngeal CA is 2.76 cases per 1 lakh people population, while the prevalence is 14.33 cases. The incidence and prevalence both are increasing day by day. So, considering the Indian stats, the laryngeal cancer contributes to 3 to 6% of all cancers in men. The age-adjusted incidence rate of laryngeal cancers is highest, that is 8.18 in 1 lakh population in Kamrup urban district of Assam, and the lowest in Nagaland. So recently this Assam district have come to a focus where a lot of malignancies have come to rise, maybe due to the younger age of smoking and all those things. The etiology, tobacco, smoking, alcohol, HPV, family history, diet, red meat diet, exposure to asbestos, nickel fumes, rushing through the history examination, palpation of the neck nodes, laryngeal crepitus, tenderness of thyroid cartilage, indirect laryngoscopy, fibrotic laryngoscopy, and NBI, that is narrowband imaging. The diagnostic pre-work, the pan endoscopy, very important to know the other digestive tract also, to find out any synchronous hidden malignancy, to find out the detailed symmetry, motion, surface architecture, evidence, maybe a wake-up call. So mobility of the vocal cords and the glottic chink. So regarding CT or MRI, CT gives the tumor volume, cartilage involvement, invasion of free epiglottic space, extension beyond the larynx, and finally the neck metastasis. CT or MRI, for the invasion of the cartilage, MRI seems to be a bit better. The intraoperative workup, the microlaryngoscopy with 0 degree and the angle telescope, that is 30 and 70 degree, and the narrowband imaging. A few words on the narrowband imaging is the endoscoping imaging technique that uses the absorption characteristic of the light to enable the detailed analysis of the vascular and the mucosal structure. So a white light passes through an N/A filter, and then a narrowband illuminations are created, and accordingly the images are seen. Like the green light is taken up by the subepithelial bark vasculature, while the brown light is taken by the submucosal vasculature, so that they have a distinct pattern. So considering the type 1, type 2, type 3, which pronounces for diagnosis of the squamous cell carcinomas. Starting with the transoral laser surgery, the power or the power density of the laser affects the what thing we are doing, whether we are going to ablate the tissue or we are going to incise the tissue. So the most commonly range we use is 1500 to 20,000 scale. So smaller lesions, we in toto remove the lesions where we have 1 to 3 mm of free margin. But for a larger lesions, we follow a piecemeal technique. It is not like just taking a chunks of the tissue, but it is going through and through, going a deep. That is the bread slicing of the tumor. We go till the depth, we assess the depth, and accordingly we remove by a piecemeal technique. Commenting on the laser cordectomies, depending upon the extent of the removal of the tissue, the cord and the deeper part, we label it as type 1 cordectomy, which is the subepithelial, type 2, which is subligamental, type 3, which is transmusculature, type 4, that is a total cordectomy we do. Type 5 is the extended cordectomy, like along with the cord, we remove the arytenoid cartilage, other things, and type C is involvement of the anterior commissure, when we remove the cord along with the anterior commissure tissue. The advantages of the laser resection: it's a preservation of the speech and swallowing, faster recovery, less pain, fever complication, as we all know, avoidance of extensive reconstruction, avoidance of tracheostomy, but the most important thing is preserves all treatment options in setting of recurrence, including radiation therapy. Considering the oncological results, transoral laser resection oncological results, the Glottic, the studies done in 2005, 2006, Steiner et al. And Mota et al. which all states that the local control is 84, 74%, 60. Regarding the functional results of the laser resection, it is all comparable to the radiation therapy. This is the parietal in 2003 suggested the type 1 and type 2 chordectomies are comparable to the control population. But this is all possible only in early glottic carcinoma, not the advanced one. The functional results of the recent study which was done in 2024, they did the spectroacoustic voice parameters for the laryngeal microsurgery versus the radiation therapy. They compared the 441 titles were retrieved and they could find they were comparable favorable reports except the shimmer. Like they did the shimmer, the maximum phonation type, the noise induction thing, and then they retrieved that other parameters of the spectroacoustic voice were all good except for the shimmer part. No, I'm not touching. My hand is quite far apart now. So a latest study of the recurrent glottic carcinoma, there are few studies which deals with the recurrent glottic carcinomas, dealing with the oncological outcomes and the failure patterns. This study showed 142 patients which concluded with the salvage chordectomy offers favorable laryngeal preservation rates and oncological outcomes for recurrent diseases amenable to the conservative surgery. This is a video showing a growth on Hopkins. Growth present on both the vocal cords, mid 1/3 of the vocal cords. This is a 0 degrees and just pre-operative. Laser resection started. The laser resection doesn't give a tactile sensation just like we do with the cold steel surgery instruments, but the suction deals a very important role in this. With the left hand, the suction doing a traction counter traction effect, and the laser just cutting the tissue. I'll fast forward it. So with the peeling apart of the tissues, we get the idea of the induration and the normal tissue. Like this is very close to the indurated area. Now this is a normal tissue which is being cut, so that we get a safe adequate margin here. Just a second. Similar procedure done on the other side. The key to access for the laser is the good exposure. Like if the anterior commissure lesion is also good exposed, and if the cartilage is not involved, then we can reset that lesion also with the laser. Thank you.
I request Dr. Praful Sakre to hand over the certificate to Dr. Manoj Jondhale. Next talk, Dr. Trupti Gadkari.